Hello, and welcome to the webinar, FQHC Application, Process and Challenges of One Community Mental Health Organization. My name is Melissa Da Silva, and I am the moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from HRSA, Office of Special Population Health. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. Thank you again for participating in this webinar event. I now turn the mic over to our MC for today's production, Mr. Dan Russell. Dan?
Thank you, Melissa. My name is Dan Russell, and I am the CEO of Genesee County Community Mental Health, and I am also your Master of Ceremonies today. Before we get started, I do want to thank the Council for all their help. They have been great to work with, and I also do want to say that we're very excited to be doing this, but by no means do we consider ourselves experts in this. This is about our experience, and if we have learned anything and if we have gained any skill, it's because we made most of the mistakes that you can make doing this. My team of presenters today includes Honor Potvin, who is a consultant, and Tisha Deegan, who is our Chief Operating Officer. I'm going to talk just a little bit about the landscape of where we are and who we are before I talk about why we did this. We are in Flint, Michigan. Flint is about 80 miles north of Detroit. We are the birthplace of General Motors and the United Auto Workers, and that still very much influences the culture in our county and in this area. Our population is about 425,000. We're the 5th largest county in the state. The Flint population is just a little over 100,000, which has dropped fairly dramatically over the last decade. And just for a little bit of information about the economy, in the 70s, Flint had one of the highest per capita incomes in the country, and there were over 90,000 individuals employed by General Motors. Today, there are less than 8,000 individuals employed by General Motors. You may have heard of Flint for a number of reasons. We lead many lists of bad health and economic indicators. Just a couple that, if you Google Flint, you'll find come to the top. Dying cities, most miserable cities, most dangerous cities. Those are the pop culture lists that can be debated one way or another. We also do have the list of the actual health demographics, and we are as equally bad on many of those. So we have had many, many challenges in the area. But I also want to say that in spite of that, I do believe in recovery and comebacks, and there is a group of very dedicated people in this community that are fighting to regain what Flint was at one time, and we are making progress. A little bit about our organization. We are a community mental health center. We are a department of county government. We're a large provider, and we're also a Medicaid manager. So we are a service provider, and we're kind of like a health plan. We adjudicate claims and authorize care in a fairly large network that we have. We deal with adults, children, and we're also the public organization that is responsible for substance use disorders. Budget was about $135 million last year. We have 320 staff. About 240 of those are involved in providing clinical care. The others are management and involved in the insurance side of our business. And we have over 200 contracts with providers in our fairly large network. We've had a collaborative relationship with our local FQHC for over 10 years. They have a clinic just above where we are sitting today, actually, and we've had that we started talking with them actually in the year 2000. We applied for the 330 funding because of the tremendous growing need in our county. Our homelessness is increasing astronomically. The economy is bad everywhere. We know that. It's a little worse in Genesee County than it is other places. We're trying to expand the safety net. We know there is a fairly huge unmet need in the county, and we wanted to be part of that. We also wanted to look at the potential for new money coming into a county that drastically needs new jobs and new money in what a lot of places refer to as a dying area. A couple things that I have learned, and I think if you're going to consider this, that you should know about. If you are the boss or you are part of the board, you must have absolute 100% commitment to this process for a couple reasons I'll talk about in just a minute. I was the one who originally brought the FQHC into the organization over 10 years ago. I have a very strong personal commitment to health and wellness, and so this was a no-brainer for me. But if you're not the boss and this wasn't your idea, you do need to be on board with this, as does your board, because it will be an all-consuming process. You must do your homework and look at how this fits into your organizational structure. It may be very different than what you think right now. I learned quite a bit along the road as to how that does work, and it was not what I thought it was going to be. You must also know where the political landmines are. You're going to need lots of support from lots of different organizations on this. Hugs and kisses are nice, but get it in writing before you undertake this, or you may have some surprises. If you are a behavioral health organization, very important to know that you probably will not be a FQHC. I still hear that from a lot of my colleagues, that, oh, you can become an FQHC and get the additional money and the good reimbursement rates. There are only a couple places I know in the country that actually have somehow managed to do that. I don't know their structure, but I know you cannot just become an FQHC if you are a CMH. It is a very complicated process, so you must really, really do your homework. This process will take over your organization for some period of time. It is very disruptive. It is very expensive. We started out with one consultant. We hired another consultant, and I pretty much sacrificed my chief operating officer and her assistant for this process, and my chief medical officer also. He was phasing out of his role due to his retirement, and I used him quite a bit. If he had not been phasing out, he would have also been taking offline. So it is a very, very resource draining process, and you have to be prepared for that. And I think the last thing that I can add is that all that said is that you have to do this for the right reasons, and that is you have to be committed to providing more access and more care for a very vulnerable population. Extra money is always good. Extra grants are always good, but if that's the only reason that you want to get involved in this process, you probably need to rethink that. You should do this for the right reasons, regardless of the money and regardless of how difficult it is, because it is very, very difficult. With that, I'm going to turn presentation over to Tisha Deegan, Chief Operating Officer.
Thanks, Dan. Our application process started about 18 months prior to hitting the submit button. Back in the summer of 2009, as Dan talked, we watched the need grow in the county because of recession, the depression that was going on here in Genesee County. In Michigan, we began talking with our consultant at that time, who had previously brokered that arrangement we have with our current FQHC. So she was very knowledgeable. We started looking at the community statistics. We started doing a look at our own readiness along the lines of what Dan was describing. We met with our Michigan Primary Care Association and our Department of Community Health. That's the state governing body for us. We had conversations with a couple of the other public entities across the country who had done this successfully, Tennessee, Oregon, and then just a couple counties over in Ingham County at their health department. We did make a site visit over there. It was very helpful to do that. I would recommend that. And by the end of 2009, Dan was ready to tell us to go ahead and do it if the funding became available. In the first part of 2010, we spent a lot of time establishing really critical partnerships, especially with the group that would be providing under contract our primary care. We started on some of the core documents that take a lot of help from expensive resources, consultants, attorneys, and so forth, like the bylaws. Started a long process of collecting technical assistance from the national staff in Washington and others. We started the official formal needs assessment process in earnest in February, and all the data analysis that goes with that. And through that process, and in kind of keeping with our mission as a community mental health center, realizing we were the biggest, the strongest, the best funded part of the safety net in Genesee County, it just made sense for us to really focus in on the most vulnerable of the vulnerable people in Genesee County. That is people without insurance, without income, without safe housing. We went on and attended a 2-day conference in Washington. That was super helpful. I would recommend that. In the spring, there were rumblings that the money was coming. We also figured out about that time we did not have to pursue a 501c3 status because we're a public entity. That was helpful to figure that out. We attended HRSA technical conferences, conference calls, started on our work plan, and started the process of collecting literally 200 pages worth of documents that would then eventually go with the application as attachments. We spent that whole spring, summer, and fall engaged with our partners in the community in the safety net. And by the middle of the year, we're ready to talk with our own board called the co-applicant board in a public application situation. We did that, and as Dan said, sent our medical director out into the community to start collecting contracts and referral agreements. That was very successful. The announcement came in August, of course, and we immediately hired Honor, whom you're going to hear from in just a moment, to perform some very specific tasks that she's got a lot of talent, and we're happy to have her. In the fall, we attended a technical assistance conference call, this time focused on special populations and performance measures. We made the decision at that time to focus strictly on homeless and public housing. It felt like that made sense in keeping with our mission and in the intent to establish programs for the most vulnerable population. We started meeting our board and advisory groups in the fall and October, and by November, Dan was able to present our plan to the county commissioners, again an extra step because we are a public entity. We made successful on-time submissions to grants.gov and then to the electronic handbook, and that's what the little happy dance there is about in December. And here we are in 2011 waiting for an announcement, hopefully sometime in August. If all goes well, we will open 2 clinics, one focused on homeless in the One Stop Resource Center and one in the public housing development in Flint called Atherton East. In the meanwhile, in the event we're not successful at being funded this round, we have prepared and will submit next week a grant for a health center planning grant to HRSA, and that will be very helpful to continue gathering support from stakeholders for a community health center. There are several things we wish we would have known in the beginning. Most importantly, that the National Health Care for the Homeless Council existed. We found that out way late. That would have been very, very helpful to know them sometime like about a year ago. It's easier than you think to get the support of really important people like the senators. And the HRSA call center, I really encourage you not to be shy. There are real people there. They answer the phone, and like when you call them, they answer the phone and have great answers and are so helpful. So don't be shy about contacting them. We also made a mistake in that my assistant and I thought it was smart to just have the 2 of us have access to the handbook, and so our entire team had to funnel stuff through us to the handbook. That wasn't very efficient. There's nothing anyone can do to hurt it until the submit button is hit, so it's okay to have other people in the handbook. We wish we would have known earlier that we didn't need to pursue the 501c3 status. We wasted a lot of time with that. It's a very good thing to do, but it's not mandatory for public entities. You've met Dan. You're about to meet Honor. My assistant Pat and I comprised the core boots on the ground team, but it did take kind of a cast of thousands or a village. All the names you see on the slide, our finance director, our contract director, certainly our medical director, our CIO, our director of substance abuse treatment, and our nursing director. All of these individuals had giant parts of the application they worked on and gathered that data together for us. I'm going to now turn the presentation over to Honor, and she's going to tell you how she really did most of the work.
Thank you, Tisha. I'm Honor Potvin, and I'm going to talk to you today about my role in this application process. I was primarily responsible for community outreach efforts, governing board recruitment, getting together a representative governing board, and also data collection, analysis, and mapping. Because I had multiple purposes, I always had an eye toward accomplishing different goals at the same time. I needed to engage both the public housing community and the homeless community since we were targeting both of these special populations. Now just to tell you a little bit about these populations in our community, the homelessness is rising. Dan mentioned that we had nearly 4,000 homeless individuals at last count, and many of those were families with children. And in the public housing population, we selected Atherton East, and there are 800 residents, and about 90% of them are single mothers with children. Also in our community, there's a wait list of over 1,200 people waiting to get into public housing. So the need was definitely there. And as I said before, I had the goal in mind of recruiting a diverse governing board, so I was always thinking about who might be a good candidate for that. And since I was also collecting data, I was always keeping an eye out for new data sources through any contacts I might make along the way. Now, trying to do all of these things at the same time often became overwhelming and a little confusing, so that was a continuous challenge that I faced. And while I'll talk more about that and how I dealt with that, I'll do that as I move through the process. So my first step was really to step back and look at the community and really look at it from a distance and identify all of the key players and examine what was available, see who was active in the community, where the services were located, and who was already partnering and working together. I found that in addition to making lists, mapping this out visually was very helpful. I'm definitely a visual learner, and it just helps me to see things, and I think when you're working in a large team, it's helpful for everyone too to be on the same page with that. So this allowed us as a team to see where the greatest need was and where the resources were concentrated. Since I wanted to capture as broad of a picture as possible, I did a lot of research to see what was out there. Many of the more obvious stakeholders like the health department, the homeless shelters, the universities, the hospitals, they were people that we already were in contact with as an organization, and we had partnered and had formed relationships with these people previously, so that was really great and really helpful. I then just started to web out from there, and I did a lot of research online and looking in news articles even just to see who was working together, who was co-hosting local events, and working together to bring services to the community. This was helpful because I wasn't familiar with some of the smaller players, people that were very active and important, but they just didn't have the same presence as our university. I also needed to identify several routes for reaching our target population directly. And luckily, as an organization that already had a network with other service providers in the area, I was able to use these existing contacts to help with this. So, since I knew this initial research would lay the foundation for some very important parts of the application process, I made sure to be very thorough. Once I had a really strong list of the stakeholders and I mapped everything out, we worked together as a team to discuss precisely what our target service area should be. This was actually a decision that went through several discussions in different phases before we settled on a subset of zip codes within our county that seemed to present the most need and the greatest opportunity to serve the most vulnerable populations. I also used this list to design and plan the outreach strategy. Because the list was so diverse, I recognized pretty quickly that I would need to tailor my efforts to reach the different types of stakeholders in the most appropriate ways. I will be discussing the components of the outreach strategy in more detail later, but I will say that using a variety of approaches really did pay off for us. From phone calls to emails to various types of surveys and public postings, each component ended up being very important in its own way. Another key outcome of this initial research was that I was able to identify some data sources that hadn't been immediately obvious to me. I built this into the outreach process so that as I would reach out to people as stakeholders, I would also be sure to inquire about, if they had any access to reports or data that wasn't published or that, wasn't readily available. From this, I really did get quite a bit of unanticipated information. And I realized that, there really is just a lot of unpublished info out there that can really help you create a successful application. So again, I was meeting 2 objectives at the same time, and that was really helpful, especially with the time crunch that we were under. So this is just an example of one of the service area maps that I did. This was created with the UDS mapper, so it was pretty simple. I used the UDS mapper quite a bit, a lot more than I anticipated using, and I'll talk more about that later. But it really was a pretty quick and easy way to visually represent things that were in the community that I could then share with the team. And we used it to envision different scenarios and different aspects of the community and what was out there. So now I will go a little more in depth about the outreach strategy. For a quick overview, let me first say that I cannot stress enough how valuable it is to use existing networks and contacts. This makes first contact so much easier. People are really busy and overworked, and if you can get in with someone that is familiar already, it just makes the whole thing go so much more smoothly. I will revisit that again as well. For our surveys, we use surveys in a variety of ways. We designed multiple versions and tailored our distribution methods depending on who we were trying to reach out to. The response was a little low, but it still ended up being an extremely helpful part of our application process. And finally, the advisory committee meetings. This was really crucial to get face-to-face interaction with consumers who are going to be the most affected by this proposal. And so just to kind of hit on some of the biggest challenges, kind of overall challenges in the outreach process that I faced, as I've said a few times, when you're trying to do multiple things at once, it can get really confusing. Right from the start, I kept very detailed notes and records, and in the beginning, it seemed almost overboard to me that I was doing it, but in the beginning, before I was completely consumed, I had the time to do that. As time went on, and we got into the more stressful final weeks of the application process, these records were absolutely essential for keeping everything straight. So take the time up front to design an organization system that works for you. Knowing exactly what day and time you spoke to which person about what topic can come in really handy in lots of ways that you wouldn't expect. It really helps you to write a cohesive narrative and just keep things straight for yourself. Actually for yourself and the entire team. So the next big thing was time. We all know time, gets away from us. We all have experienced this, but somehow it still seems to happen over and over again. So no matter how much extra time you think you are leaving for something, I can tell you right now it's probably not enough, and you should probably double what you expect for that, whatever given thing to take. So start early, leave some leeway, and also we as a team imposed a lot of internal deadlines that were really pretty far ahead of the hard deadlines, and I think that's one of the most important things you can do. Internal communication is another really important part, especially if you have kind of a bigger team like we did, but even if you have a small team, I think it's really important. There were so many people doing different things, and you often just couldn't anticipate how those things were going to overlap. So to be as efficient as you can, we really sent progress updates out to our entire huge team. And it did clog our email inboxes, and it definitely was a little overwhelming. But it also worked to our advantage numerous times because someone on the team would know something or know someone that could help when you least expected it. So having a clear expectation across all the team members that everyone is going to get these updates and needs to be checking them is a really good idea and something to implement and agree on from day one. So these have been mostly internal challenges, but the external challenges that I faced really mostly centered around follow-up. Again, in a community like ours where the demand for services is so much greater than the supply, and people are very busy, very hardworking, and they definitely want to be involved and they want to be helping, but if you're not following up regularly enough, they're just going to move on to the next pressing concern because surely there are more waiting. So, keeping that line of communication there, keeping it regular, and also just sharing that excitement with people, I found to be a great tool. Now going back to existing networks and contacts, this was crucial. Really take the time to explore what your networks have to offer. Really think through who you might be forgetting or leaving out. Ask people that you may think it's a long shot, but really reach out to everyone you can think of. Specifically, one great resource I'd like to highlight for us was the United Way. In our community, the United Way has taken the role of information gatherer and disseminator, and they run about 4 groups in the county to try and coordinate community efforts such as housing, basic needs, children and families, and senior services. They've done this for about 4 years, and what they do is they disseminate information through these networks. And I think most of the communities or the county's social service organizations participate in one or more of these community planning groups that the United Way runs. So most social and outreach agencies can be reached with a single request. Now, I've been working in this area for a few years, and I knew the United Way ran these groups, but it really didn't occur to me that they had these email blast kind of lists until I met with our internal manager of communications and public relations here at our organization. She recommended that I use this list. She was aware of it, and she also had some other dissemination strategies that were really helpful. So if you have access to a person in your organization who does public relations, I definitely recommend meeting with them. And if you don't, I still would recommend finding someone in the community that would talk to you about what's out there, because this is their job and they probably know a lot more about it than you do. So that was amazingly helpful. Another huge advantage was our existing relationship with the One Stop Housing Resource Center. The One Stop provides a variety of services for the homeless and near homeless in our community, including assistance with finding housing. So this was really helpful for gaining entree into both the special populations that we were targeting. Finding a similar type of resource that has such a good reputation in the community will be a huge benefit for you and your outreach efforts. Now, I also worked through some other internal networks that we had. I spoke with the Director of Substance Abuse Services here at CMH, Christy, and she was able to get a list of referrals from local recovery programs that we were involved with. We identified 14 people this way, 5 of whom became interested in the governing board. So that was really helpful for reaching out to consumers. I also met with Bill Dobb, our supervisor of community housing, and he was able to connect me to the local housing authorities, and it was especially useful meeting with him because I was able to get the attention of an extremely busy and overworked leader in our community. Since Bill had already formed this relationship, I was kind of able to jump in and just take advantage of that. It was really time-saving, and given our limited time frame, extremely valuable to get these discussions moving along like that. And I already mentioned meeting with our public relations person. So the surveys. Surveys were very useful. Sometimes they didn't seem like they were going to be, and I was just really hoping that our response would come back, big enough to make it worth it. But I think because we tried so many different distribution methods, it really was helpful. I knew we would need a lot of these different methods because we had so many different types of stakeholders. And probably the fastest way to reach the most people was that United Way email list. It was really efficient and went out quickly and kind of spread. People sent it to other people, and that was great. I also revisited my initial stakeholder list, and I directly mailed about 25 surveys to some targeted individuals, mostly business and nonprofit leaders. I didn't just mail these. I also emailed or made some quick phone calls to these people to introduce myself and give them a heads up that these surveys were coming. And then I also followed up to let them know that I had mailed them, and we were just hoping to get them back. I Also, something that seems obvious but you might forget, I included a stamped return envelope, and I also made sure that the survey was quick enough to complete really, that it wouldn't take a lot of time. So this actually, the response rate was much higher than I expected, and it was even higher than the email blast. And that surprised me, but I think after reflecting on it, I think people are kind of just overwhelmed by email, and they're inundated with emails all the time. So it might be nice just to have a piece of paper to quickly fill out and throw back in the mail. To reach the community and our consumers, I also distributed the surveys at our advisory committee meetings. I didn't just hand them out or leave them to pick up. I actually offered to sit with people after the meeting or before the following meeting to go through the survey with them. I made sure it was short enough to complete quickly and relevant so people would be interested in completing it. I had a really great response rate through this approach, and I offered to do individual meetings with people or talk to them over the phone about the survey. And I think people in the community seemed really eager to discuss the issues related to accessing healthcare. And I think the offer to sit down with people just kind of personalized that survey taking experience. And it was something that people really appreciated. So that was what led to the great response rate on that. I also distributed the surveys through local homeless shelters. I sent them out to some of the directors and transitional housing specialists that work at some of our local homeless shelters. And I asked that they distribute the surveys on site and possibly even identify a few people that they think might be really great candidates to fill out the surveys that maybe have something important to contribute. And the response rate on this was a little lower. I think the people working in those shelters are very busy, and I think they did the best they could. Even though the response was low, I still think it captured yet another piece of the puzzle for us. And then finally, I left copies of the survey at the management office of the public housing location that we decided to target. I asked the office staff to bring attention to the survey, and I put a flyer there explaining the survey when residents stopped in for any reason. Also, to further maximize our access to the public housing community, I was able to pull addresses of our own consumers to see who lived at this particular public housing site, and I then made phone calls directly to about 150 people, asking them if they would be interested in completing the survey. This, again, wasn't our most successful approach, but I do think it added to the overall picture that we gained, and I think reaching out to people in any way you can to get this information back is worth it. So the surveys really did help us in our grant response. We gained a better idea of how the community felt about our organization and our ability to bring new health services to the community. We were also able to identify what was currently working for people, what they were happy with, where they had positive associations and experiences, and really feel out what people wanted to see. And then we also were able to, on the flip side, hear what was especially frustrating or difficult for them when trying to access care. We had an idea of what we thought the barriers were, and through these surveys we were able to verify that kind of straight from the mouths of the consumers rather than us just sitting in a room and guessing. So some of the results were exactly what we expected, and others were a little surprising for us. One example of this was hearing that some of our consumers were going to emergency rooms for preventative care because they had become accustomed to the immediacy of care from times when they had visited the emergency department in the past. So if they had to wait a few days or sometimes weeks to get an appointment, even if it wasn't an emergency, they would opt for the quicker service in the emergency department. We knew that people were visiting emergency departments, but we often thought it was because they didn't have any other options. And here we were able to find out that some people who have other options are still choosing emergency care based on their familiarity with it and just the overall convenience. So that's just one example of a lot of the really great information that we got from these. We also used the surveys to collect information about marketing and implementation of a new health center. We asked about trusted sources of information in the community and how they found out about new services. And we also asked for their ideas when it came to spreading the word so we could get an idea of what were the most valuable approaches to take in the future. And finding out what mattered to people the most when it comes to things like extended hours and providing child care during doctor visits was also another useful part of the surveys. And again, all of these things really just helped us create a successful application narrative response. The advisory committee meetings was another key component of our outreach strategy. We had a variety of methods for identifying participants, and we really knew that we needed a formal way to gather people together and discuss the health center proposal with them. So to find people for this committee, we reached out to local homeless shelters and asked for referrals and help spreading the word about the meetings. And as I mentioned before, we used our existing contacts to reach out to the substance abuse recovery programs as well. Both of these tactics worked quite well. I also posted public announcements and flyers in locations where I thought the target population would see them. And we held the meetings in our main building because it's a familiar location to the community. It's centrally located and easily accessible via public transportation. This is a very important thing to remember to do. If you're going to hold these meetings, it really needs to be somewhere in the community that people are comfortable going. People even mentioned to me at the meetings that they really appreciated that the meetings were here and that this was a convenient place for them. So I do think that really matters to people. I also encouraged people who were attending the meetings to tell others about the committee and the meetings. I would always announce the next meeting date at the current meeting so that people could help spread the word, and I would even have some flyers available for them to give to other friends in the community that they had and other community members that they interacted with. So these meetings were very successful and led to many positive outcomes. They really helped engage the community and gain their trust about our proposal, and they also helped to spread the word. They're very effective. Most importantly, though, it was another resource for collecting the stories and experiences of the people who mattered the most in this effort, the actual consumers themselves. This was also the most valuable way to identify consumer board members. Some attendees at these advisory meetings were clearly committed to this effort and really showed that. They came to every meeting, and several ultimately did become members of our governing board. So I didn't just have these meetings and hope for the best, also because I knew how crucial they were to this whole process. I collected email addresses and cell phone numbers, and I asked permission to follow up with attendees. Everyone agreed, so I was sure to call and email everyone in between the meetings. This seemed to really help keep attendance steady, and it also helped people open up and be more comfortable since we formed an ongoing relationship without too much time, lag in between. So it really was a very important part, I believe. And I also really felt like it really mattered to people that we were taking the extra time to continue that conversation with them even between the meetings. So moving on to another big part of my role was data collection. And sorting through data and evaluating the credibility of data and becoming completely swamped and overwhelmed with data was my life for quite a while. So I'm going to go through some of the biggest challenges that I faced. Data consistency is huge, and there's just so much out there and so many different years and different geographic subsets and comparisons. It can really be a maze that you will get lost in. What would have been really helpful for us would have been to agree as a team what our baseline was going to be. We had a few different people working on data, and we would get into situations where someone had collected data from 2005 through 2007, and someone else had collected data on 2009, and then we needed those pieces to fit together in ways that they just didn't. So we had to go back through after the fact, which was much more time-consuming, and make adjustments. And of course, you can use data from different years, but you have to do it carefully and be very explicit about what you're doing Otherwise, you're going to read or lose your reader, and the person's going to lose faith in the argument you are making. So agreeing as a team up front, what your parameters are going to be is a really helpful thing to do. You also need to think about your service area in advance and be sure that you know exactly what it's going to be and that you aren't going to change it before you start your data collection. We actually switched our service area ever so slightly once we got partway into the application process. Didn't seem like it was going to have a lot of significance, but it did end up having a huge time-consuming effect on the data collection efforts. A lot of things had to be recalculated, and I just don't think we anticipated how much time that would take. So avoid this if at all possible. Time. I can never say enough about time. Start the data outreach process early on. There are tons of resources available, but people are busy and special requests often don't happen overnight. People really appreciate it when you give them some leeway. And this wasn't always possible for us, and luckily there were some great resources. And there were some people who were willing to give us data at the last minute and really assist us at the last minute. But you really should not and cannot count on this. So really get in touch with people as early as you can. Really think through what data you might need and make those, more importantly though, make those specific data requests. Just don't let time prevent you from doing that. And choices. There are a lot of different sources, oftentimes several sources for the same data, and you do need to choose between them. And this is another place where working through existing contacts is helpful. Find the expertise in your community and take full advantage of it. I found it really helpful to talk to other people in the community who had a role of collecting data for their organization and find out what they thought were the most useful or most reliable sources of information when I had to choose between different sources. Also, always check the references. I found many gold mines by looking through the references of various reports. So, the report itself may be helpful, but then you see something that they used and you find out that's even more helpful for you. And again, checking those sources can also help with accuracy. So again, data can be very tricky, and if you don't have a person dedicated to it at your organization, and even if you do, it can still be really tricky. So I'm going to share what I found to be especially helpful. So first of all, I'm going to say right up front, take the time to watch tutorials and read instructions. Watching tutorials often seems, you're in a hurry, you want to get the data, you go to the site, you think you can do it, but it's much faster to just take the 5 minutes and watch the tutorial. And a lot of times you realize that the data source is actually much bigger than you thought, and you can get a lot more from it than you thought. So a lot of those online resources are just immense, and that can be a huge time saver in the long run. The American Fact Finder, I'm not sure how much people have used it, but it is definitely an amazing resource. They are transitioning now to a new Fact Finder 2 for the new Census 2010 data, but you can still use the original version because the new version is still kind of in the process of being created, and a lot of the 2010 data isn't available yet. There are lots of different ways online if you've looked around to access census data, but I found the American Community Survey detailed tables to be the most efficient and just sort of complete source of information for our application. You can access very small subsets of data like zip codes and census tracts, and just for a wide variety of different things. Now, sometimes the data isn't really representative of your community for many reasons. Sometimes it's a local organization who is collecting more accurate and current data on a given indicator, like health insurance, for example. But it's always good to address this and provide both pieces of information, and the American Community Survey detailed tables are a great source for that. Another huge resource, as I'm sure we all know, are the health departments. We regularly use reports from both our local and state health department. If you speak directly with an epidemiologist at the health department, there is often unpublished data as well that can really be of use. So definitely seek those people out if you don't already have relationships with them. They are usually more than happy to help you, even if they are overworked and it may take them a little while to do it. They are usually very willing to cooperate. In our county, we have a homeless management information system administrator, and if you can find someone like that for your service area, this was tremendously useful. I can't imagine going without this resource. We were able to access a lot of data specific to the homeless population. We were able to get detailed information about the composition of the homeless population in our area, the primary reasons for experiencing homelessness, the services that people were accessing, and just a whole bunch of other vital information. And we also were able to get the most recent unpublished data this way, so definitely seek this out. We also had the pleasure of working with a data guru at our state primary care association. I learned how to present data extrapolations in an acceptable format for our application response. I had been able to do it in the past, but I didn't really understand how to show what I was doing to the reviewers of the grant application, and this was really helpful to see how to format that. This person also had access to some data that I couldn't find, so again, that was a great resource. The Bureau of Labor Statistics is also another excellent resource. I really like the way that their website is designed, and they have all kinds of tables and statistics and reports about trends in unemployment and earnings in your area. And again, it's another thing that you want to cross-check if there are people who are local organizations who are collecting this information. You do want to compare the sources and address any differences that you might find. The UDS mapper ended up being not only a source to get information about existing FQHC services, but the mapping function was really a great resource for us. I used it extensively. I probably created about 30 different maps by the end of the application process. And even if you have access to someone with GIS and other mapping abilities, UDS Mapper is just very easy to use. It's quick and it's much simpler and less time consuming than other mapping applications that I have used. So I did use that quite a bit, and I definitely recommend it. The HRSA Geospatial Data Warehouse is definitely a place you can get lost. It's definitely a warehouse online. There's a lot of information there, so be careful. I found it especially useful for checking the medically underserved area and medically underserved population and health provider shortage area designations. But there's a wealth of other info on there, and it also has many different mapping functions that you may find useful, so watch those tutorials. And again, I just want to stress the value of foundations and national council reports and checking with your local university research center. And make sure you reach out and contact people directly. It's often worth the time because, again, there are unpublished data sets that people are willing to share. So, and also if you don't understand the data, the unpublished data, be sure to ask for help because people are always more than willing to help you understand that. And with that, I'm going to pass this back to Melissa for a Q&A session. Thank you very much.
Thank you, presenters. Dan, Tisha, and Honor for that breakdown of your extensive process and some challenges in completing an FQHC application. We have just a few questions here. Actually, I just saw 4. But 2 questions I'm going to combine for Dan. Dan, how did you locate and fund the consultant, I'm assuming honors position, dedicated to the work on your FQHC application? Dan?
Thank you, Melissa. Good question. The initial consultant we used was paid for just with what we call general fund. It's flexible dollars that we have discretionary use for, and that's what we use for honor also. These didn't take away from any of our treatment efforts, and it's always the money that the state looks to take back at the end of the year if we haven't spent it. So it was money well spent. As I said initially, we used 2 consultants. Our initial consultant was an individual that I've known for quite a while and who was responsible for helping us bring the FQHC relationship to fruition from the very beginning about 10 or 11 years ago. So she was active throughout this. Honor was actually a graduate student intern we had from the University of Michigan. In addition to public health, she's also a computer whiz. So when she says the geomapping is pretty simple, I would take that from a real narrow perspective, that it's a little more than Googling things, and it is not just something that you can pick up very easily. So we were blessed to have two people who knew the process, were great with research, and were also resilient in digging for the things that weren't real evident.
Thanks, Dan. Our next question, I think, is trying to get at how you all took on this challenge of transitioning from a mental health organization to a comprehensive healthcare organization. And I think this questioner is trying to get at just how you plan on building in primary care. This very specific question from another participant is, do you already offer primary care in your mental health org? And how have you, what are your designs or strategies for bringing primary care if you are indeed funded in the FQHC?
We already have some primary care in our organization through the existing FQHC. The funding that we're going after would expand that into the homeless population and the public housing populations. We don't intend on terminating our relationship with the current FQHC. We're very happy with that. They do a great job. We just want to expand the services to the populations in the county that are growing the fastest.
Thanks, Dan. I wasn't exactly sure who to direct that kind of convoluted question to. Our last question is about the surveys that were distributed, and Ralph is interested in knowing if you have examples of your surveys that were distributed, I'm assuming to share with our webinar participants.
Thanks, Melissa. Yes, I absolutely have those surveys available to share with people. I have quite a few different versions that we used, and I'd be willing to send those out to whoever is interested in seeing them.
That concludes the Q&A portion. I don't see any other questions. We'll be sure to also attach any surveys or other materials that you share with us to the archived webinar. And I just want to now turn the presentation mic back to Dan for his closing remarks before we conclude this production.
Thanks, Melissa. I think just in closing, just a couple things. As you've listened to this, I hope you got that it was quite a journey for a mental health organization to go through this. It was also an enormous amount of work. We had lots of surprises and lots of challenges. And the other thing I hope that you picked up is that the people that I was fortunate enough to have working on this are very, very bright and were very committed to this process. So if you're looking at doing this, if you haven't done this and you want to do it, again, do your homework very, very well. See how it fits into your organizational mission and your objectives. Make sure everybody is 110% behind it, because it will change your organization, at least in the short run. Looking back over this now, I believe that I would do it again, knowing that it was an enormous amount of work. Most of our scars have healed, and even with not knowing that we have a good chance of being funded, it was a great experience. I think the team all gained from the experience, and we would definitely do it again. The need in Flint continues to increase, and at the end of the day, what compels me to say we would do it again is if we had not done this and had not at least made the effort, I think we all would have not felt that we were doing our jobs, whether we're successful or not. I think we knew this was something that we had to do. So it was quite a journey, and I wish you all very good luck if you choose to do that, particularly if you are behavioral health organization, and a lot of this will be new territory for you. Thank you, Melissa, and thank you to the council for giving us this opportunity.
Thank you again, Dan, Tisha, and Honor for sharing your experience completing or developing the FQHC application for HCH and PCPH funding. Thank you, participants, for joining this webinar, again produced by the National Healthcare for the Homeless Council. This particular production is a part of our community development work, and for more information on our community development project, please contact us directly and ask for either myself, Melissa Da Silva, or our associate, Melisha Edwards. Thank you again for your participation in this webinar. It has now come to a close.